Uh, Hello.
Hi, Aryaman.
Hello, sir. Good evening.
Hi, good evening. How are you?
I'm good, sir. How are you?
Yeah, I'm good.
Yeah. So we'll wait for like another 5 minutes. I think few of them are still trying to join.
Yeah, yeah, sure, sure.
Yes, sir.
Dear students, many of you joined through my link. So please mention your name when you join. So whatever the link, I think even you got a link when you registered. Even the link which I shared you, please join through your name. Please join through your name. Please mention your name when you join, or rejoin with your name, please. Otherwise it is showing all, whoever join, it is showing on my name only. I request all the audience, please rejoin with your name.
వచ్చిందా గూగుల్ తో ఓపెన్ చేసినావా ఇది మనోజ్ కుమార్ ముడికి ఇన్ని ఉన్నాయి
Requesting all the audience once again, please change your name.
Dr. Manoj, can we start the session?
Yes, Arif, one moment. One
Okay. The speaker is here.
moment. She has some.
Okay. Okay.
మళ్ళా
Aryaman speaker is joining in a moment.
Okay, so once she joins, we can start the session.
Yeah, yeah.
Good afternoon, Manoj. Am I audible?
Ma'am, good afternoon, ma'am. You are audible, ma'am. Yeah, Aryaman speaker is here, Dr. Saraswati ji here. So we'll start the program.
Good evening, everyone. Good evening, Dr. Saraswati. Good evening, Dr. Manoj, and all participants who have joined us for this webinar.
Good afternoon.
Hello,
Hello.
ma'am.
Yeah.
Uh, at the very outset, I would like to welcome all of you to this fourth episode of our webinar series, which is being organized by Kalam Institute of Health Technology and supported by all ISPOR India chapters. So, I would like to welcome all of you also on the behalf of our Chief Operating Officer, Dr. Kavita Kachru, Kalam Institute of Health Technology, who is not able to join today due to some other commitments and other meetings that she has. So she sent her regards as well. So, just a brief overview of what Kalam Institute of Health Technology is. So, KIHT or Kalam Institute of Health Technology aims to facilitate focused research on critical components pertaining to medical devices by supporting institutions involved with research and development, industry, policymakers, and knowledge repositories. And this shall be achieved through transfer of technical knowledge and bringing strategic and coherent synergy of scientific facilities and institutions to complement efforts on industrial promotion in the medical devices segment. This webinar series is not just a routine knowledge sharing platform. It is a part of a broader mission to nurture a forward looking ecosystem where evidence based policy and public health impact outcomes. Through this initiative, we aim to empower our professionals and institutions to stay ahead in the era increasingly shaped by real world evidence, AI, and precision health technologies. Today's topic, we have unlocking genomic insights through real world data and for better healthcare outcomes and decision making. The global shift towards data driven healthcare is now more evident than ever, reflected not just in practice, but also in the highest honors of science. Uh, if you know about the 2024 Nobel Prize in Chemistry, which was awarded to David Baker, Demis Hassabis, and John Jumper, their groundbreaking work in computational protein design and structure prediction using AI, particularly with tools like AlphaFold, has completely transformed our ability to design new proteins and understand molecular mechanisms of diseases. And David Baker, while he's a professor in University of Washington, Demis and John, they are working in Google DeepMind AI. So this is not just about chemistry, it's about how AI and real world data is becoming central to medicine, diagnostic, and treatment planning. So to enlighten us on this topic, we have Dr. Saraswati GR, Professor and Head, Department of Pharmacy Practice, Faculty of Pharmacy, Ramaya Institute, Ramaya University of Applied Science, Bangalore. Dr. Saraswati is a highly esteemed academician with over 22 years of experience in teaching and research. She leads the Pharmacological Modeling and Simulation Center at FPH, which focuses on computer aided drugs, design, and discovery. Requesting all participants to mute when they join so that the webinar can proceed smoothly. Dr. Saraswati has earned several accolades throughout her academic career, including the Women of Science Award from Ramaya University of Applied Science. She was awarded the Tamil Nadu Pharmaceutical Science Welfare Trust scholarship for her postgraduate research and was ranked first in her Master of Pharmacy program. She also received the Best Outgoing Student Award from KM College of Pharmacy. As an accomplished speaker, Dr. Saraswati has presented her work at various international conferences, including the International Society for Pharmacoeconomics and Outcome Research in Tokyo and the Asian Conference on Pharmacoepidemiology in Brisbane. Currently, Dr. Saraswati is dedicated to drug repurposing research, especially in the context of neurodegenerative diseases like Alzheimer's and Parkinson's disease. She has published over 50 research articles in renowned indexed journals with a cumulative impact factor around 100. In addition to her research and academic duties, Dr. Saraswati has been involved in community oriented initiatives, coordinating interdisciplinary programs that offer medical services to underserved villages. We are so honored to have you with us for this session, ma'am.
Thank you, Ariman, Raj. Good afternoon, everyone. First of all, I would like to sincerely thank the ISPR India Andhra Pradesh chapter, the president-elect, and all the organizers for inviting me to speak at this insightful webinar. It's a pleasure indeed for me to be with you all. Can I get the my PPTs? Would you be?
Yes, ma'am, I can share it.
Yeah.
You want me to share, Ariman?
I'll share it, sir. I'm sharing it.
Okay.
Is the screen visible, ma'am?
Yes.
Yeah.
How about the audience?
It's visible now.
Visible. Okay, nice. So today's session is centered around unlocking genomic insights through real-world data for better healthcare outcomes and decision support. So herein, I'll begin by providing an introduction to what is pharmacogenomics, explaining how PGX forms a foundation for precision diagnosis that drives the therapeutic success. So we will initially explore how the genomic data can predict the therapeutic efficacy, also the potential toxicity, and this will enable us into more of personalized and effective treatment strategies. We will try to understand personalized and effective treatment strategies. And this will be followed by my colleague, Dr. Sri Raja, who will delve into the economic perspectives of genetic testing to either understand efficacy, response rate, prognosis, or the safety profile, and use of real-world databases. There are a lot of databases wherein they are all open resources, so that you can get into such databases to understand what kind of guidelines are derived from those databases, or biomarker discovery can be one line of research for many of the researchers in pharmacy practice. So this will enhance us into a lot of scope to get into clinical decision making and optimize the healthcare outcomes. So we look forward for engaging into more informative session with all of you. So initially, to start with, pharmacogenomics. Pharmacogenomics is basically for predicting the therapeutic success, the response or adverse drug reaction, any kind of drug related things which are related to the genomes basically. So pharmacogenomics is a study that deals with the relationships between genomic variations and their effect on the drugs. So here you look at it at this picture. So when traditionally when you are giving a drug to a group of people, so there are different responders. Good responders, people do have partial response. There are no responders. Also, people do have adverse drug reaction. This all are depending upon their genetic makeup. So traditional medicine is given to everybody. It is not tailored to an individual. Wherein precision medicine with the background of pharmacogenomics will have a tailor-made prescription for an individual based on their genome level. Next slide. So pharmacogenomics is going to govern the choice of the therapy in future. So this is the base of it, and we will be thinking, will it be cost effective? Probably initially we will think that a lot of testing takes consumes the laboratory investigation, and you have to put in money. But once the panel is ready, it is as good as having a tailor-made drug, because because the patients will be mostly benefited, and the therapeutic success will be very high as we are tailoring to that individual genome. So let us go inside this topic, we will understand it better. Next. So here we say the genomics-driven comprehensive healthcare represents a transformative approach wherein every step is guided by the genomics. So precision decision, diagnosis to personalized treatment. So the diagnosis is based on the early biomarker. So you can be identifying the disease well in advance. Based on the biomarker, you will understand what kind of treatment will work for that particular individual. Not only based on the biomarker of the disease, also based on the genetic makeup of the patient, you will be understanding if this drug will have a good safety profile in that particular patient. Because if the metabolizing enzyme is not sufficient, if the gene which is encoding for the metabolizing enzyme has a loss of function, the patient do get adverse reaction associated with that. And this will lead to the clinicians to predict therapeutic responses, adverse reactions, and this will help us to optimize the clinical outcomes. So this integration of genomics into clinical practice will lead to more accurate, efficient, and effective healthcare tailored to each patient. So this should be the goal of emerging healthcare system. Next. So herein we look at the genomic insights that play a crucial role in the healthcare spectrum completely. So herein you have the susceptibility of diagnosis and prognosis. For example, BRCA mutations, BRCA1 or 2 mutations that will serve as a biomarker to indicate this patient may have a susceptibility to get a breast cancer or ovarian cancer, enabling early screening and preventive strategies. So this is one such biomarker which is widely used to screen the breast cancer. And accordingly, the therapy also changes. If there is a BRCA mutation, the therapy changes to olaparib or niraparib from a normal breast cancer therapeutic pipeline. And then about the diagnosis. So herein we have cystic fibrosis, where there are CFTR gene mutations, which is confirming the cystic fibrosis, and targeted interventions are based on the CFTR and its mutations. And in oncology, the 17p deletion. So that is the p53 gene deletion with any kind of cancer, and especially chronic lymphoid leukemia. This serves as a biomarker for poor prognosis, influencing the treatment choices. So similarly, BRAF mutations in skin cancer, not only in skin cancer and other cancers, this also will aid in the targeted choosing of the targeted therapies and improve the patient outcomes. So basically, from susceptibility to the safety issues to the monitoring parameters, if we have a proper genomic landscape of a particular patient or group of patients, it would be really ideal to have a healthcare system which will have therapeutic success and safe outcome. Next. So this is one example for, you can just press it to me. So this is one example for the breast cancer therapeutic pipeline. Initially, we go with the history and physical examination, then go with the US imaging and mammogram MRI. Then you will have to look at the metastatic profiling if there is a distant metastasis. And then go into biopsy IHC, wherein if you find the gene which is expressing estrogen receptor or progesterone receptor, if it is ERPR positive, the treatment would be anti-estrogens, anti-progesterones. And if it is HER2 positive, the treatment would be trastuzumab or pertuzumab. And if it is triple negative, means ERPR negative and HER2 negative, you will be checking the BRCA mutation. If at all BRCA mutation is there, the choice would be PARP inhibitors, olaparib and niraparib. In case of breast cancer, you have properly framed or designed a pipeline. it is not only cancer we have to have such therapeutic approach. It should be in every diseases. For example, antipsychotics, usage of anti-epileptic, and cardiovascular system. So everywhere, if we have some pipeline like this, it would be really ideal for having a good success with therapy. Next. So this you can see a boy sitting with a magazine. Actually, to see the small boy who is in the magazine is the boy who is holding the magazine. It is around 20-25 years. There is no drug or no genetic biomarker for cystic fibrosis. So this magazine tells that past 20 years, 20-25 years, we did not have a therapy for cystic fibrosis. And then they understood the gene underlying the cystic fibrosis is CFTR gene mutation, wherein this is affecting the chloride channels, the chloride transport, and this is thickening the mucus, and mucus plug is so thick, and there is an imbalance in the pH. And this leads to lung disease and pancreatic insufficiency, malnutrition, and all associated with cystic fibrosis. So, getting understood about the genetic mutation, it was very easy for the scientists, the drug discovery scientists, to get into a drug discovery. Next slide. So here we are identifying the responders of responders for the treatment of cystic fibrosis with ivacaftor. So when you look at ivacaftor, it is working, ivacaftor and lemacaftor, they are working on the CFTR channel. Ivacaftor is potentiating the CFTR channel, and lamacaftor is stabilizing the conformation of CFTR, so that the mutation is made stable, and the mutant proteins are taken away. And there are few biomarkers like G551D who are showing better benefit with these drugs, wherein if there is a 508 del mutation, they are not showing benefit. So when cystic fibrosis is being treated, if we can check for this mutations or the strains, it is actually good that we will understand the responders versus non-responders. Next. So when do we need pharmacogenomics? Is it required for all kind of drugs or all kind of diseases? Maybe no. We will be looking at pharmacogenomics, especially if there is a multimodal pharmacokinetics with respect to the drugs, and drugs like narrow therapeutic index drugs like digoxin or any of the anti-epileptic immunosuppressive agents. And if there is a high variability with the drugs, and if there is a race effect or ethnicity effect, and the safety profile is very low. So for such drugs, it is actually ideal to go with pharmacogenomic studies. Next. Pharmacogenomics, the first focus usually will be with the metabolizing enzymes. So we have different categories of metabolizers, like you have a poor metabolizer, intermediate metabolizer, ultra rapid metabolizers, and normal metabolizers. So when there is a prodrug, the metabolism should be good so that the prodrug will be converted to active drug. In case of poor metabolizers, the prodrug will give loss of therapeutic action. Wherein when we have active drug and there is a poor metabolizer, there will be adverse drug reaction. So depending on the metabolism status, you may have to increase or decrease the dose, or sometimes you have to withhold the offending drug when the adverse reactions are very serious. Next. Next slide, please. So classical example of this pharmacogenetics with the CYP2D6, 2C9, 2C19, DYPD, TPMT. So UGT1A1, these examples are there even with my slides. So these are the metabolizing enzymes that we have to really focus on, wherein if there is a poor metabolizer given this, administered with these drugs, there will be very severe adverse drug reaction that you will not be able to control. Sometimes it is life-threatening even. Next. So these are few examples to predict toxicity through pharmacogenomics. One is DPYD versus fluoropyridines, TPMT and NUDT15 mutations with thiopurines, and G6P, glucose 6-phosphate dehydrogenase deficiency versus rasburicase, and UGT1AN, 1A1 with irinotecan and belinostat. So we can go into. So this DPYD allele versus 5-fluorouracil and capecitabine. So usually this fluoropyridines are converted to non-toxic dihydrofluorouracil. 5-hydroxy 5-fluorouracil is converted to non-cytotoxic dihydrofluorouracil. So if there is a low or absence in activity of DPYD because of either 2A or 13 allele, this will lead to a deleterious impact because of extreme mucositis, diarrhea, neutropenia, and neurotoxicity, both with capecitabine and 5-fluorouracil. Next. So there is a guideline from CPIC. CPIC is basically the Clinical Pharmacogenomic Implementation Consortium. So this is giving guidelines based on the metabolizing capacity of each individual. So there is something called as activity score here. The patient who has activity score 2 is called as normal metabolizer. Intermediate metabolizer is 1.5 or 1, and poor metabolizer is 0 and 0.5. So click. So when a patient is normal metabolizer, you can go for a normal dose. If he is intermediate metabolizer, you have to go with go with 25% to 50% dose reduction if he is 1.5, if he has an activity score of 1.5, and there will be a dose reduction of 50% if it is 1. And for poor metabolizers, you should not give 5-fluorouracil. So generally when we give 5-fluorouracil and find neutropenia, mucositis, diarrhea, so we say this is an adverse drug reaction. But we have to look into the scenario that if the DPYD enzyme is not active, and is it because of that this person is getting into such problem? If so, it is not an adverse reaction. It is the wrong patient whom we are treating. So this is how the pharmacogenomics is going to change the purview or perspective of treatment. Similarly, TPMT and NUDT15. So those are with thiopurine, 6-mecaptopurine. It is converted to thioguanine nucleotide, which is less toxic, and there will be increased myelosuppression, life-threatening myelosuppression, and this is more seen with European or African ancestry. Next. Yeah, this is again similar to that, TPMT and NUDT15. So these both are causing elevated TP, and these metabolites are cytotoxic and leading to myelosuppression. Here it is Asian and Hispanic ethnicity. So based on ethnicity, also we have to look at. So European ancestry is there. You need not check it in Asian. If you have a good cohort and find it is not there, it is okay. But if Asian ancestry is there, the ethnicity has a NUDT 15 allele, then it is ideal to check it and then go for the therapy. So as per the consortium's guideline, TPMT normal metabolizer should be given with 75 milligram per meter square per day of mercaptopurine. Next. In case of intermediate metabolizers, it is a dose reduction required for about 30 to 80% than the normal dose. So normal dose will definitely cause adverse reactions in poor metabolizers and intermediate metabolizer. Next. And in case of poor metabolizer, there should be 10-fold reduction in the frequency, and it should be thrice a day. It is not once a day, it should be thrice weekly. So this is how there should be a treatment protocol, so that the normal dose will not fit everybody based on their own metabolizing capacity, their own metabolizing enzymes mutations. Each patient should receive the therapy. So that is the background of having a pharmacogenomics. Next. Similarly, glucose 6-phosphate dehydrogenase, and it is alarming that 400 million people display glucose 6-phosphate dehydrogenase deficiency. Not only with rasburicase, it is the deficiency will cause hemolytic disorder with many of the drugs possible, anti-malarial, salicylates, and so many. So here, rasburicase is a recombinant urate oxidase enzyme, and this is used in hematological malignancy to prevent tumor lysis syndrome. And when there is a G6P dehydrogenase deficiency, there is methemoglobinemia and hemolytic disorder. Next slide. So it leads to hemolytic anemia and methemoglobinemia. So the treatment mainstay goes with high flow oxygen, ascorbic acid, and blood transfusions. Next slide. Next is about irinotecan. Irinotecan and belisimirsate. They both will cause diarrhea in patients who have mutations with UGT1A1. So basically, UGT1A1 converts irinotecan into non-toxic substance. There is a glucuronidation required. If there is a 28 allele, there is one allele and 28 allele. If both the alleles are 28, then there will be a devastating diarrhea, and people die of it because of SN38 levels, high levels of SN38, and that irritates the intestine. Next. So in case of intermediate metabolizers or poor metabolizers, UGT1A1 will result in greater levels of SN38 metabolite because it is not glucuronidated, both in irinotecan, also in belinostat, both are anti-cancer drugs. And this leads to life-threatening neutropenia, also diarrhea. So as per the next one. As per the Dutch working group, so initially CPIC I have explained you. Similarly, there is a Dutch working group. So they have derived guidelines for irinotecan and UGT1A1 mutation. So if there is a 1 and 28 allele, they are intermediate metabolizers. So there need not be any drug dose adjustment, wherein if there is both the allele being star 28, they are poor metabolizer, and we have to start with only 70% of standard dose, and if the patient is able to tolerate it, then we can go for the full dose. We have to keep checking the neutrophil count and look for the diarrhea. If it is not life-threatening, we can go with the normal dose. Otherwise, 70% dose only we should be starting for somebody who has a UGT1A1 28 being a poor metabolizer. Next. So this is related to PGX to predict the therapeutic response. So here we have CYP2D6. So you can go to the next slide. This is related to tamoxifen. Tamoxifen, as we all know, it is a prodrug and it should be converted to endoxifen. So for the conversion of tamoxifen to endoxifen, you need CYP2D6. If there is a mutation in this enzyme will not work, and so tamoxifen will not be converted to its active metabolite. So in this case, you have to increase the dose of tamoxifen. So for when we predicted toxicity, we will reduce the dose by half, or 30 to 50%, or 30 to 80%. We had a dose reduction. Wherein here, when there is a CYP2D6 enzyme deficiency, it is ideal to increase the dose of tamoxifen or go with an alternative drug. Next. So this is where it is told. Either tamoxifen dose can be increased to 40 milligram per day, or alternative therapy like aromatase inhibitors like anastrozole or letrozole can be added to the treatment. Next. This is about ABC binding acids. These are glycoproteins which will cause efflux of paclitaxel. Paclitaxel is it's an anti-cancer drug. It's a spindle poison. It has to get into the cell for its activity. So ABC ATP binding acids having a mutation will activate the efflux pump, and the drug is highly effluxed out, and there is loss of therapeutic function. So in such cases, you may have to increase the dose of paclitaxel. Next. This is about the predictive biomarkers for tumor response, wherein we have positive biomarkers and negative biomarkers. EGFR mutation and ALK mutation, especially in non-small cell lung carcinoma, here they are actually good responders. If there is EGFR mutation or ALK mutation, it is they are considered to be having a good response for the inhibitors like gevitinib or ALK inhibitors. While on the other hand, negative predictors like KRAS mutation with colorectal cancer, they will not be responding. They are not good responders for anti-EGFR antibody therapy. When we know such genetic markers are available, than choosing the therapy initially, it is always good to go by choosing the genetic profile of the patient and make the treatment accordingly. So this is precision medicine, or you go with a tailor-made approach for an individual person, and so you have a therapeutic success as well as you will prevent adverse reactions. Next. I will hand over this forum to my colleague. So she will be Dr. Sri Raja, and she will be explaining about the economic perspectives of genetic testing, how it is helpful, and also about various databases, how you can delve into those databases to understand the genetic predisposition and the risk factors. Thank you. Thank you for inviting me.
Thank you, ma'am.
Hello, everyone.
Hello, ma'am.
Am I
Should
audible?
we start? Yes, ma'am, you're audible. You can start
Okay. Yeah.
with the session.
Yes. So I'm just going to pick up where Saraswati ma'am left off. So actually, there's an echo of my voice.
No, ma'am.
Is it okay? All right. Yeah. So basically, here.
One second.
Yeah, sure, sir.
Yeah. Let me introduce about you. So Dr. Shreya is Assistant Professor of Faculty of Pharmacy, Department of Pharmacy Practice of Mayo University of Applied Sciences. She is working over there. She is a part of the team of pharmacy. She is working with Saraswati ma'am to take up the various projects for the pharmacology modeling and simulation center. So I welcome Dr. Shreya to take forward economic perspectives. Thank you, Shreya.
Thank you, sir. Thank you for the introduction. So like I was saying, I'll just pick up where ma'am left off. So basically, with whatever ma'am explained, pharmacogenomics sounds very impressive, right? So basically, where you can just check, you can take a person's blood or tissue and you can just genotype that, and then you see that these genes are, faulty, or there's a mutation in so and so gene, which means you have to give them so and so treatment. So it's very good, right? So what
Ma'am, your
actually,
voice is breaking a little.
right? 1 minute. How about now?
It's fine now, ma'am.
Yeah. So what I was saying was that, like, it sounds too good to be true, right? But the thing is, it is actually true. So even though here in India, at least, we have not been seeing a lot of it in many disease areas, but in oncology, it is in practice, right? So here, basically, in our current standing, right? So it's not just a scientific breakthrough; it's currently an economic imperative. So we think, okay, when you think about things like genotyping and next generation sequencing and things like that, you think, okay, this is going to be very expensive, right? But there have been studies, which we will delve into now, that show that the expenses outweigh the benefits, right? So which is why, taking into account this genotype, that is, using genotype guided therapy, can really help in improving the patient outcomes, and can also save a lot of money to the payers. Basically, it can be the government or third party payers or the patient itself, right? So here, the main question that we want to talk about is it economically justifiable to test every patient's gene before starting treatment, right? So that's where the pharmacoeconomic analysis comes about. So here we have your common analysis techniques that they use, like cost effectiveness analysis, cost benefit analysis, etc. So here today we will just be talking about like the incremental cost effectiveness ratios. So here I'm just going to go into some examples, right? So, and the main goal of this pharmacoeconomic analysis is to kind of strike a balance between the clinical benefit and economic value, so that you can basically make decisions based on the genotype. So that's why it's called genotype guided therapy. So the first example we have here is of warfarin. So as you all know, warfarin is a very commonly used anticoagulant drug, which is used in case of stroke prevention, atrial fibrillation, a lot of other issues like that, right? So the problem with warfarin is that it has a very narrow therapeutic window, and when you dose it too less, the stroke risk increases. But if you give too much of it, then there can be life threatening bleeding. So this is something that we all know. But in case of warfarin, there are two genes, specifically the CYP2C9 and the VKORC1, right? So these two play a major role in how these patients metabolize the drug and respond to warfarin. Okay, so the CYP2C9 affects the drug's clearance from the body, which is it's associated with the metabolism, whereas the VKORC1 deals with how sensitive the patient is to the effect of warfarin, right? So based on the variations in these genes, the different patients respond to the warfarin in different manners. Okay, so when they found that, so basically in this study which we're seeing over here, all this data is taken from a meta-analysis of a systematic review of the economic studies for genotype guided therapy. So here, in case of target population, that is mechanical heart valve replacement, atrial fibrillation, and ischemic stroke patients, they found that when they use the CYP2C19 and the VKORC1 genotype guided therapy, that is based on this, the levels of this, the genes or the mutations in these genes or the variants, they found that there was a considerable cost benefit, right? So these clinical studies that evaluated the economic impact basically said that in the US here, the ICER ratio was $13,000 roughly per quality adjusted life year, right? And this is well below the 50,000 which is in the normal threshold, right? So of course when you're doing the genotyping, that is when you're checking the genotype before you're giving the therapy, the cost reduced, and there was also a benefit. So then in UK there was a similar result. So they saw that in the when the normal threshold was 20,000 pounds, it came down to 6,700 pounds per quality adjusted life year. And similarly, in case of the Sweden, it was 250,000 the currency value, and it while the threshold was 500,000. Okay, so this is some of the examples in case of warfarin. So can we move on to the next slide? So this example is regarding azathioprine. So this is a very commonly used immunosuppressant, and the main ADR over here that we're trying to prevent is bone marrow toxicity, that is severe myelosuppression. Like ma'am explained, this myelosuppression, this TPMT gene, like we saw, it's to do with many thiopurines. So here, in case of the European and African ancestry, the TPMT gene is what you have to test for, and based on this testing you can see whether or not it is beneficial. However, in this particular case, the testing was a little bit more expensive, and it was not as it did not considerably reduce the threshold, which means that although this kind of testing is available and there is some kind of scientific justification for performing the testing, you must always perform these kind of studies to confirm whether it is actually beneficial to the patient in terms of economics and overall well-being, right? So that's one example. Then we have, but also this is just one example I've taken up. There are also other studies that have shown that testing that does work out less expensive for the benefit gained. Okay, then we have carbamazepine. So this is a very commonly used anti-epileptic drug. So here they found that the HLA-B allele, that is the 15 is to 02 allele, basically here it showed that those who had this allele, particularly those of the Asian ancestry, was strongly associated with Steven-Johnson syndrome and toxic epidermal necrolysis, and both of these are very fatal skin reactions, right? So here also we found that performing the testing before and then avoiding the drug or altering the dose showed that the cost to the government was a lot lesser in case of those who were insured by the government, right? So they saved approximately 9.85 million Thai baht. This study was done in Thailand. And they found that this reduction was mainly because they could avoid the cost associated with the ADR, treating the ADR. Right? So this is one more way how pharmacogenomic testing can help you pharmacoeconomically. So what this basically says is that overall genotyping improves both the clinical outcomes as well as the economic value, and testing is clearly a cost saving intervention. So when this and if the testing facilities are available, the clinical the clinicians should push towards going in this manner, that is nothing but individualizing therapy and performing precision medicine. So ultimately, the value of pharmacogenetic testing depends not only on the biology, but also on the clinical context, the population characteristics, and the economics of implementation. So here, when it comes to researchers and areas for a study, making sure that you can stratify patients based on the area. For example, if the patient is of European ancestry or African ancestry, you might not have to perform the TPMT gene testing. You might only have to perform the NUDT15. This is not I'm just giving an example. This is not exactly there's no evidence for this, but I'm just saying. So if somebody is able to stratify patients like this, we can further reduce the cost of even genotyping the patients, right? Instead of genotyping all the genes for all the drugs, we can very select the specific genes and genotype for them. So this is actually happening in case of cancer therapies, but this should be pushed to other areas of therapies as well. For example, in cardiology or even in case of psychiatry. So even in psychiatry, we see that there is a lot of drugs that are given, and there's a lot of trial and error that happens. So if we're able to identify certain genes that show that this patient will have a good response to this drug, it will avoid the unnecessary cost and also the unnecessary side effects for this patient, right? So that's basically the point of why that's basically what we wanted to show you in case of this economic perspectives. So can we move on to the next slide? So now coming to the real world databases. So here, this basically in this section, we basically want to show you that the whole uh, the whole thing about how you genotype patients and give therapy is actually very much uh, it's very possible to implement that in the clinical setting, and budget should not be the only thing that is setting us back. So here, uh, basically these databases provide robust evidence-based resources that can translate genomic profiles into concrete clinical decisions. So these databases don't just tell you, okay, this is associated with this. It also tells you that, okay, if this gene is, or this mutation or allele or variance is present in this gene in this person, this is the this is the clinical action you must take, right? So all of the data is annotated and present in this database called the farm GKB database. So this database is it's like a culmination, or like it contains suggestions from these two main guidelines, as we can see here, which is the Clinical Pharmacogenetics Implementation Consortium, that is CPIC guidelines, which ma'am was talking about earlier, and the Dutch Pharmacogenetics Working Group guidelines. So, but recently they've also added the FDA drug label information as well. So this Farm GKB, that is the what is it? The pharmacogenomics knowledge base. Basically, it combines the suggestions of all of these different databases and guidelines, and it makes it a very user-friendly kind of tool to help in making decisions. Right. So what happens? Here is, so this real world data, when you combine it with the decision support systems like farm GKB, it helps us ensure that right drug and right dose for the right patient. So this can be achieved using these databases. So in case of CPIC, like just to give you some more information, so they provide peer reviewed evidence based guidelines that help translate genetic test results into actionable prescribing decisions. So here the focus is on translation. So you would have heard of translational research, translational medicine, right? So these working groups basically aim to convert all these research findings, convert all these trial findings into translatable and clinically actionable recommendations. right? And as such, as we know, with any kind of guidelines, they give the recommendations in terms of the level of evidence. For example, they have level 1A, 1B, level 2, AB, and level 3 and 4. And the level of the strength of the evidence reduces as the number increases. So level 1A, of course, is the highest evidence, and if it's a 1A evidence, it's a very good recommendation, and you can follow that recommendation. While it goes to, if you go to level 4 evidence, it basically means that there's not well documented evidence for a particular suggestion. So these guidelines, so the Clinical Pharmacogenetics Implementation Consortium, that is CPIC, as well as DPWG, they basically give these recommendations. So the next thing that I wanted to continue about, so basically here, if can we go back actually? So I can give you like a quick demonstration of how the farm GKB database works. So if you can just
Yeah, yes, ma'am. I'll stop sharing.
um, not able to share this.
Ma'am, I've made you the co-host now. I think you can share.
Yeah, is my screen
Yes.
okay?
It's visible.
So this is the page that opens up when you look up farm GKB. So as you can see here, they have a very nice user interface, and their main information is available on this GSI genotype selection interface. And newly, they've also released a mobile app, which makes it even more easier to kind of access this data, because they're, like I said, their main focus is on translation. More recently, they've also started annotating data that has been focused on children, that is the pediatric pharmacogenomics. So as you can see here, over 100 drugs have been annotated, and this is done manually. So they have a team of curators who manually check studies and guidelines, and they will update the information regarding that gene in their knowledge base. So there are two ways to go about looking or searching in their database. So one is looking for the gene. So for example, if we put CYP2D6, okay, so you just look this up. So you get different results, and these are the individual variants. By variants, they mean like a particular mutation in that gene, right? Or you can click on this gene totally, like it'll give you all the possible information that they have, or all the annotations they have in that particular gene. So they have 174 prescribing information. They have 119 clinical annotations and 68 pathways that they have curated for this CYP2D6 gene. So here in the overview page, we get something called the VIP. So this VIP is nothing but very important pharmacogene. So these are genes that the farm GKB people have annotated as very important, because they have some known pharmacogenomic implications. So this is just an overview of all of that. This is the location. So where they are expecting uh, the mutation or the variants to happen. And these are some of the other information regarding that gene. So now coming to the prescribing info, when you click on this prescribing info, you get all this information regarding the genotype phenotype based prescribing information. So here what it means is that when there's a particular variation in the gene, what type of phenotype it results in. Is it to do with efficacy? Is there a change in efficacy? If the mutation results in a toxicity, like that. So there are different things that you can see with this. So I'm not sure if you can see, 1 minute. Yeah. So here, as we can see, they are talking about the source. They tell you about the source, which is CPIC. So all of these recommendations have been annotated from the CPIC database. And then this is the different genes and the associated genes with CYP2D6. And this is the guideline where they have taken the information from. So as you can see, this is for amitriptyline and CYP2C19 as well as CYP2D6. This is for atomoxetin. Like that, there are all of these other drugs as well. Now coming to the drug label annotations. This annotates the regulatory agency approved drug label. So when the FDA approves a certain mutation and says that, okay, if this patient, they have found in the trials or whatever, that this patient, if they have this mutation, you must do this kind of testing, or this kind of treatment must be given. Those kind of label information, if it's present, that is annotated in this section. So as you can see here, in case of this drug, for example, eliglustat. So for the gene CYP2D6, there is testing required. So they say that if you're going to give this drug, right, you must test them for this gene, that is CYP2D6, and based on this, you must give the drug, right? So if you click on details, you get more information regarding this. So this particular information is from the EMA label, that is the European Regulatory Authority. So their label for this drug is giving all of this information regarding that drug. So this should not be used in patients who are ultra rapid metabolizers, and all the patients must be genotyped before you give the drug. And in adults, they recommend the dose is 84 mg twice daily, intramuscular, and the recommended dose is 84 once daily in per metabolizers. And then we have pediatric population, what the dosing recommendation is. So like this, you have all this information regarding that one drug that has been taken from the thing. So here, as you can see, it says testing required. Apart from this, they also have other annotations. So if you click on this information section here, you'll be able to get it. So the first one is testing required, which means that you absolutely must test the patient for that particular genotype or that particular gene before you proceed with giving that drug. Then you have testing recommended. So this label states that some sort of gene or protein testing should be done, so so that the outcome will be better. Then we have actionable PGX. So this says that there is some kind of action also that can be taken. That is, not only do they tell you test, they also tell you exactly what kind of action should be taken. Then we have informative PGX. So here they say that particularly they don't know exactly what kind of effect it has on the patient, but they just give you for the information sake that this kind of variant is observed in these patients. Then we have no clinical PGX, that is, there might be a variation, but this variation is not associated with any kind of phenotype. That is, it does not affect the drug's efficacy, dosage, metabolism, or toxicity. Then finally, they have the criteria not met label. So this basically says that it doesn't fall in any of these other criteria. So they would have annotated it in this way. So as you can see, this area also gives us a lot of, so it's useful for clinicians, but it is also very useful for researchers. It's also very useful for, health policy makers and implementation scientists and translational researchers, because it helps them look for areas where more work is required. So as you can see, for this gene, there are a lot of drugs that need to be, that you need to be aware of before you can start dosing them. So this is all the different labels like I was telling you about, right? So this is one way to go about it. And apart from these two, you also have a lot of other data that you can get from here. That is clinical annotations. This tells you exactly what the level of evidence is, where the publication is from, right? And also what variant. So this, when the star mark is there, it means the allele, they're referring to that allele, right? So all of these alleles are what they are saying are associated with this drug. So similarly, these alleles are associated with ondansetron. Like that, we have different information regarding, and also the phenotype. So here we see these alleles for this drug is associated with metabolism, while these alleles for ondansetron is associated with efficacy, and this is associated with toxicity. So different drugs and different alleles are with different phenotypes as well. Okay, so these are a few things that I want to show. So this is the first thing. So you can search for the gene and see what kind of drugs are there, or which is what more commonly you would come across is that before you give a drug from a clinical standpoint, before you give a drug, you will be able to look it up. For example, tamoxifen. If we search here, we will be able to see if there are any genes that we need to test for before giving the drug. So this is more, of course, clinically useful. because first people will be first you see the disease and then you look at the diagnosis. But also the assumption made by the CPIC or the spam GKB the organizations is that in the near future, or sometime soon, that all the doctors or all the clinicians will be will have access to the genotype data of all the patients. Like you would have seen, a lot of new startups and companies are coming up where you can yourself approach them, and you can get yourself genotyped, right? And it'll tell you, they have little packages as well. So they will tell, for drugs or for diseases, if you want to genotype yourself, and you'll have that data, you can always carry it with you, and you can go to your doctor saying, see, I got this done, and this is my genotype, right? So when in the near future, when this kind of data is available, the clinician is more equipped with more data, and using tools like this farm GKB will help them make more informed decisions, right? So here we can see that when we put the drug, we get, based on the different guidelines, what kind of different working groups, what kind of guidelines are available. So in CPIC, there's a guideline for tamoxifen and CYP2D6, and same for all. So it looks like for tamoxifen, CYP2D6 is the only gene that they are currently worried about. So here, if you go to the drug label annotation, similar thing is also found here. So tamoxifen, as you can see here, testing is required according to the FDA, and there is an actionable PGX from the Swiss Medic Regulatory Authority, right? So these things can be taken into consideration before we go for the treatment. So, for example, if you click on details for this, which is the FDA label, in the FDA label, they say before you give the drug, you have to check for the level or the mutation for the tamoxifen. So this is just another way that you can go about searching. There's also a lot of other information. You can also look at literature and see how the people have manually curated based on what information. Then we also have pathways. So this is also very useful, and this is something that people in research would probably look at. So here, if you look at this pathway, it tells you exactly in which way the genes or the drug is getting affected. Okay, so downstream analysis can be done and all of that. So this is just something that I wanted to go over. So the demonstration is also something. So can we go back to the slides, please?
Yes, ma'am.
Sharing, right?
Ma'am, can you stop sharing your screen so that I can?
Yeah, 1 minute. I'm not getting the. I think it stopped sharing. Can you just check?
Yes, ma'am.
Yeah.
Is the screen visible?
Oh, yes. Yes. Yeah, so we went over all of that. So now coming to another database, which is called the UALCN database. So this is like a database which is very specific to cancer. So here, this database is not used that much in translation, but comes into picture when you want to research a particular gene in different cancer data sets. So here, the database will collect the information from this TCGA, which is the Cancer Genome Atlas, which is the data of the US data for cancer, where they have genotyped multiple patients having different types of cancers and generated certain data sets, which is specific to certain cancers. So using the data from those data sets, this website or this tool will give you different kinds of analysis. For example, it will give you survival analysis using the overall survival or the Kaplan-Meier plotters, or it will give you gene expression analysis. That is, they will compare the gene expression in cancer patients versus normal. And you also have methylation analysis. I think you guys have heard of epigenetics, right? Where the methylation is a very common thing, which can, without any changes, or there is no mutation or no change in the sequence, but the way that gene is coded is different, because there are some environmental factors that will cause turning on or off of these genes, but the sequence remains same. So this is called epigenetics, and that also you will be able to look at some analysis in this data set. And then we have pan cancer analysis also. So one particular gene, how it is expressed in different cancers, right? That also you will be able to see. And there are of course links to other databases. So this is one of the data sets. I mean, one such database. So if you can just go forward, there are screenshots of how it could work. So yeah, so this is again, CBio portal is also a web interface that can help you analyze this TCGA data, which I mentioned earlier. This is also something very useful. GAPIA is again very similar to ULCAN. So I will just show you how, with screenshots, how you can use ULCAN to perform any studies. So you can go to the next slide. Yeah, so this is the page that opens up when you click on or when you look up ULCAN. And here, when you click on TCGA, you can just move to the next slide. You show this page pops up. So as you can see here, you can select one gene, or you can put a set of genes and select which TCGA dataset you want to work on. And this TCGA dataset basically refers to the different types of cancer datasets that they have. So here they have taken these 3 genes and they have selected breast invasive carcinoma. Next. So you click on explore, and then, so here, this is all the analysis that I just told you about. So for each gene, they will give you the link for the expression analysis, which is to see how it is expressed in cancer versus normal. It'll give you survival analysis where you can get the Kaplan-Meier plotter and see what kind of overall survival, and if it is significant, you will be able to see that. Then methylation analysis, correlation, as well as pan cancer analysis, which is explained. So you can just go to the next one. So here they have clicked for the first gene, which is the S100P. So here, if you see, the expression levels is higher in the tumor versus the normal. And if this is statistically significant is also seen here. So if you see the comparison, the statistical significance, it mentions that is 1.6 to the power minus 12. So which is definitely significant. So this S100P is a gene that is significantly upregulated, or there is increased expression in case of the breast cancer versus normal. Next. Right. Next, you can filter this data even by the sample type. So here the sample type is normal versus tumor. You can also see in different genders, like male versus female, what kind of expression is there based on the patient's race, like Caucasian, African American, or Indian ethnicity. So what kind of races is there? But mostly in case of this, since this data is collected from the US, the ethnicities are limited to those ethnicities over there. Then we have age to see how the expression levels are there in different ages. Then, of course, there are again subtypes within the cancer and a few other things that can be available from the data set. Next slide. So, okay, you can just move on. So this is the pan cancer analysis. So as we can see here, this gene is particularly increased in a few of the cancers, while in the others it's not. So when you take a look at the overall pan cancer analysis, you can see that, is this gene something that is very specific to our cancer of interest? That is it specific to breast cancer? Or is it something that is in general seen in a lot of cancers? That is it like a something to do with the pathophysiology of a particular or cancer in general, like in the development of cancer, the progression of cancer, right? Those kind of things can be observed in this kind of pan cancer analysis. And the short forms are as you can see the below, the abbreviations are nothing but the official abbreviations given by the TCGA for the different types of cancers. Next slide. So this is again the same thing. So this is where you can click on the pan cancer the view over here. Again, there are other links for methylation, survival analysis, etc. Then next slide. So this is the methylation analysis. So here you can see that there is hypermethylation and hypomethylation in different areas, right? And this also is statistically significant, you can say. So next, so basically we're switching back to show how you can choose a different thing. So I'm sorry that the little circle is supposed to be in the highlighting the individual buttons over there, but yeah, it's moved away. I'm not sure why, but yeah. So now if you click on survival over there, next slide. You'll come up with this. So this is like your typical Kaplan-Meier plotter. It'll give you the overall survival, plus it'll give you a p-value to tell you if that graph is significant or not. So this is that. Next slide. Think yeah. So this is GEPI2. It's very similar to your ULCAN, except in case of ULCAN, they take only the TCGA data. GEPIA2 also takes into consideration data from the GTEX database. Okay, so that repository also is considered here. So that's why the overall survival values and all can be slightly different for the same cancer as well, because the data is taken from a larger data set. Right, so this is one more data set. So if you can just quickly go through these slides, it will tell you the same thing. So you can perform survival analysis. So this is again, can you just, yeah. So here, if you do a quick search of the gene, the ERBB2 gene is nothing but the HER2 gene, which ma'am was explaining about, which is very common in breast cancer. And also in case of gastric cancer. So here you can see the distribution of this gene expression in terms of different organs, in case of tumor and in case of normal patients. So this is one such thing. Next slide. So that's it. So this is basically what we wanted to cover for this session. So thank you.
Thank you, Shreja. Any queries, guys?
Yeah, thank you so much, ma'am, for that insightful session. The floor is now open for questions, and I request all participants to turn on their camera as well, so that when we have this Q&A session, it's more of an interactive session. Any questions?
Hello, madam.
Hello.
So it is a good webinar. Okay, it is full insights about pharmacogenomics. Thank you for your good information about pharmacogenetics, ma'am. Thank you. Thank you very much.
Thank you.
Yeah. So my doubt is, suppose, for example, the patients who are poor metabolizers or intermediate metabolizers.
Okay.
So how to know us? Because of cancer, definitely chemotherapy, it leads to toxicity.
Correct.
Even normal metabolizers or poor metabolizers or intermediate metabolizers also getting toxicity. How to know us, or maybe clinicians or maybe anyone? So when you go, what is the stage where you are going to check the testings, genetic testings,
Yeah. So the genetic
so
testing
that you
needs to be
can have a
before you
good.
initiate therapy. Yeah. Sorry.
Okay. Yes, ma'am. Continue, madam. Thank you.
Yes, so
Continue.
like ma'am explained, right? So we had the CPIC guidelines. So those guidelines are based on the fact that you have available the genotypic data of that patient. So if it says that, okay, based on this genotype, this patient is a poor metabolizer, then we recommend starting the at a lower dose or starting at 30% of the dose or 70% of the dose. Those recommendations are based on the fact that you have the genotypic data of the patient before you start the therapy. And the aim of this pharmacogenomics, like you just said, right? So everybody gets ADRs. That's correct. So the point of this is to reduce the fact that to reduce how much ADRs are actually happening, right? In one sense of the term. So, and genomics is pharmacogenomics is not only to do with toxicity. Also, it also tells you if one treatment is going to be successful or if there's going to be a response to that treatment versus no response. So that is also one of the things that you can look at, right? So there's multiple things, and yeah, ADRs can be avoided. That's what. So maybe everybody in one particular area, for example, are poor metabolizers. So that's why you're saying, okay, even if we give the drug to that patient, no matter which patient, everybody is getting ADR. But regionally, like I said, there can be variance, right? So maybe all the patients do have some kind of mutation, which is why they're all getting that ADR, which means you have to give a different treatment, right? So the point is to identify these kind of inconsistencies and to identify these variants so that this precision medicine can happen and individualized therapy can happen. I hope that answers your question.
Ma'am, we have few questions in the chat. Sahiti is asking, can we know whether the databases which you have mentioned are available at free of cost?
Yeah, so that's a very good question. So yes, all of the databases that we covered right now are available free of cost. You can access them and you can use them for whatever purpose that you want to use them, and they're completely free. So that's not a worry.
We have one more question from Abhishek.
Mm-hmm.
Uh, how can pharmacogenomic testing be integrated into routine or daily clinical practice to improve patient outcomes in oncology?
So mainly this should start at the policy making level where it comes as a policy or comes as a guideline where you say this treatment is dependent on this genotype, right? Like I was telling you when you check in the farm GKB database. So many of these things are in the FDA label where they say you have to genotype this patient, only then can you give this drug in this dose, right? So those kind of things should be implemented. And like I was saying, in cancer, those things are there. For example, for HER2 positive patients, we know we can give them trastuzumab, right? So those kind of things need to be well established via clinical trials and everything. And then you can make the policymaker should make the recommendations and then it should be implemented. And like I was saying, one of the major things is cost. So these things can be more easily implemented in countries or governments where these kind of tests are insured, right? But of course, for the normal person over here in India, to get these tests done is very expensive. For example, to get a whole panel done, you would need about 15 to 10 to 15,000 minimum if you want to privately get it done somewhere. And that is not for all the genes. This is by very specific genes, right? So it becomes actually like a implementation level question. There's a lot more to it than just directly applying it. So yeah, so it is taken so long in terms of cancer. So for other areas also, you need to it starts with the policymakers and researchers as well.
That answers the question. Do we have any? There's one more question. Can you give an insight about the complications of using pharmacogenomics in treatment level? This is asked by Sahiti.
Okay, so complications as such, so there's no inherent complications. You're not doing anything to the patient actually here for any complication to occur. It's basically like a blood test. If I have to say it very simply, like you are going to take the patient sample and then you're going to genotype the patient, right? And then you're going to report. So there is no inherent harm to the patient as such with performing a test, right? Like you would perform any other test. For example, for cardiac troponins. You take the sample and then you test the patient for these troponins and you say, okay, these levels are high, so we have to do so and so treatment. It's very similar to that. So there's no inherent harm in performing them. I think the only drawback in case of that I can think of right now is the cost. The cost is going to be, it is quite expensive. So which is why you have panels, right? So that you don't have to genotype the whole, the entire genome of the patient. You don't need to get to know. You just need to identify certain specific genes that can be relatively cheaper. So besides this, there's no harm to the patient as such, from doing pharmacogenomic testing.
I have a question, ma'am. Like you mentioned about many databases.
Mhm.
Uh, has there been any effort to develop like indigenous genomic databases using Indian patients' data to check
Yeah,
the
so actually
relevance of
that's
pharmacology?
a very good question. So actually, it is lacking in that area, and it's very surprising because Indians have such a wide variety of, types of people and different ethnicities and heritages and all of that. So it is very important to actually have Indian data. So what I can say in terms of that is like, I was talking about the TCGA, right? The Cancer Genome Atlas. So similar to that, we have something called the Indian Cancer Genome Atlas. So it's just new, it's relatively new, of course. And currently they have released the breast cancer data. So they have taken different patients and they have genotyped the breast cancer, and that data is been put out, but it's not as user friendly or as robust as the American data, because of course it is still in the infancy stage. And like if you want to request that data, you need to kind of apply, and you get some permissions and all that, and then you can access the data and perform your research, right? So that is one thing that I'm seeing. But other than that, annotating on this level, like the how the CPIC people have done, I don't think there's anything in India that has done something like this, which is why it is the need of the hour, especially because we have such a huge population here and the variance is like very high.
Thank you, ma'am. Do we have any more question from any of the participants? Uh, Sudhir asks, like, any government hospital, research center, in private center doing genomic testing for research work. I
Yes,
don't
yes,
think.
definitely. There are a lot of people who are performing, doing this research. Uh, Definitely would be there. So it's not uh,
In
mainly
this, I
here.
can say that Bangalore Genomic Center is working on it, and various other genomic centers. I think even with Ramaya also, I think we have some MOU with a genomic centers. I think.
Yes, sir. So on the investigator level, things are happening, and of course, the main thing for these kind of studies is the funding. So wherever the funds are there these kind of studies are happening. But yeah, definitely people are doing this kind of research on different levels, private hospitals, government hospitals, yes. But yeah, so it's happening, but it's more should happen is basically what I'm trying to say.
So I'm so happy to say that Shiraja is my student. Sorry, she was my student, and I'm proud Shiraja. You are
No,
here.
not was, sir. Always your students, sir.
Yeah, yeah, thank you so much. Yeah.
Uh, Ma'am, like just one more question to when you talk about the cost effectiveness and the economical part of it, like which models are best suited to evaluate the cost effectiveness of pharmacogenomics in India?
Okay, so I'm going to be very honest. So like my strength doesn't like completely in that, but from all the studies that I've looked at so far, it's commonly what I see is the incremental cost effectiveness ratio. That is what is commonly utilized everywhere, and even like I was saying in this systematic review that I was looking at, or even regular reviews, I've seen this is the most common thing that they're using as a measure of effectiveness. So I think that is what I've noticed, but I'm not an expert in that area, so I can't give you a more in-depth answer. But that is something that I've observed, I can say.
I think that's it. And thank you so much, ma'am. And thank you, Dr. Manoj, for facilitating such an informative and wonderful session. Thank you, ma'am. Dr. Kavita really wanted to come here, but then she has some other meetings to attend. So she sent her regards, and I thank all the participants for joining. I hope that this was an informative session. Those who want the presentation, we'll share it with you, and also this session has been recorded, so we will share it with everyone once we edit it and put it on the YouTube platform. Thank you so much, ma'am. Once again, thank you, sir.
Thank
Thank you
you,
so much.
Iman. Thank you, Shiraja. Bye bye.
Thank you, sir. Thank you. Bye.